3. Perfect. Give it just a few seconds. All right, I'm going to go ahead and get started. Hello, everyone. Thank you for joining us today. I'm Dee Dee Gardner, Chief Research Officer for the Allergy Asthma Network. Welcome to this afternoon's webinar. We are in for a real treat today with Dr. Vikram Tejwani as our presenter. We have a few housekeeping items before we start today. First, all participants will be on mute for the webinar. We will record today's webinar and post it on our website within a few days. You can find all our recorded webinars on our website at allergyasthmanetwork.org. If you scroll to the bottom of the page, you'll find our recorded webinars and any upcoming webinars. This webinar will be 1 hour, and that includes time for questions. We'll take questions at the end of the webinar, but you can put your questions in the Q&A at any time. The question and answer box or Q&A box is at the bottom of your screen. We have someone monitoring the chat if you have any questions or need help. We will get to as many questions as we can before we conclude today's webinar. We do not offer continuing education credits for this webinar. We do offer a certificate of attendance if you need it for your records. A few days after our webinar, you will receive an email with a list of the supplemental documents and a link to download the certificate of attendance. We will also try to add that link to the certificate in the chat box. So let's get started. Today's topic is biologics, turning the tide on severe and uncontrolled asthma. Despite optimal use of inhaled and oral therapies, some people still have uncontrolled asthma. So how can biologics improve control? The mission of Allergy Asthma Network is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. Today, it's my pleasure to introduce our speaker, Dr. Vikram Tejwani. Dr. Tejwani is a physician in the asthma and COPD centers at Cleveland Clinic, where he joined after completing a pulmonary and critical care fellowship at Johns Hopkins University. Dr. Tejwani is an active scientific investigator in both asthma and COPD and an assistant professor at the Cleveland Clinic Lerner's Center College of Medicine. He's passionate about patient education and translating nuanced evidence and data into actionable recommendations, and has enjoyed partnering with Allergy Asthma Network on numerous patient-centered and academic endeavors. We want to thank Amgen for funding support to make this webinar possible today. Thank you all for being here today. Dr. Tejwani, I'll turn it over to you. And Dr. Tejwani, I'm not hearing you.
Great. Sorry, I was just having some issues with the mute button, but thank you, Dee Dee, and to Allergy Asthma Network for organizing this. I'm really excited about the topic, as I'm sure many of our attendees are. It's been really a wonderful, it's been a good time to be an asthma physician. A lot has been changing over the last several years, and to some degree now we have kind of a good problem, which is when to deploy therapies for refractory cases and which therapy to deploy. So these are better problems than were present, a decade ago when it was really just systemic corticosteroids. So again, Dee, I want to thank you, the Allergy and Asthma Network, and Amgen for organizing and supporting this. So in brief for today, I'd like to go over three main criteria regarding biologics in asthma. One is just a review of the burden of severe asthma and some epidemiologic data to kind of parse out how prevalent that actually is. Two, which will kind of be I think the main focus of the talk, is consideration and initiation of biologic therapies. And then three, although as I've alluded to, and as I know many on the call know, we've really come a long way, but of course there's still some limitations, both with initiating and discontinuing biologic therapy. So we'll try to touch upon those and where things might be going moving ahead. So to begin with, there's kind of varied definitions of severe asthma, but in brief, it's asthma that requires high dose inhaled corticosteroids or or oral corticosteroids for control, or is uncontrolled despite this. And I just want to highlight, this is different from difficult to treat asthma. And there's a nice image that was in the most recent GINA guidelines from last year in 2022, which this is all based on a single study that was published in 2015. And I'll just note, particularly for our audience in America, is that this data is from the Netherlands. So kind of a different population, a little bit more homogeneous, a little less confounders in terms of ethnic variability, socioeconomic status variability. So these numbers won't translate exactly to different populations across the globe. But I do think they kind of highlight that, among your asthma populations, you have a number of those, roughly 24-25%, that require high intensity treatment. And then a number of those that, despite that high intensity treatment, don't really have great symptom control. And this is the difficult to treat asthma definition. Then you have a very small, or a smaller minority of these patients. Most estimates in America suggest that this number is actually 5 to 10%, different from the 3.7% that was demonstrated in this study in the Netherlands. But that despite this high intensity treatment, and importantly, good adherence and inhaler technique, still have poor symptom control. And this is really the population that that biologics are geared to address. So it's really this 5 to 10% of very severe individuals that biologics are geared toward. And we'll kind of hammer home three take-home points from this. And I want to start with just ensuring that you actually do have an accurate diagnosis of asthma and guideline-based therapy. And we'll come back to this in a couple slides. Before we do, I really enjoyed this study, which most studies that go over asthma essentially say that asthma is responsible for this many days of work missed, or this many days of school missed, this many dollars to the healthcare system or otherwise. But this study, what they actually looked at was, if you took all the individuals with asthma that are uncontrolled, so probably in that 20 to 25% range, and you actually got them well controlled, how much money would that translate into? And it's actually really a huge amount. So this is not curing asthma. This is just controlling asthma. So taking individuals that are not controlled, and either through inhaler therapy or biologic therapy, getting them well controlled. And what this graph shows is that it would be approximately $15 billion per year in direct costs that would be reduced. And then if you count missed days of work, missed days of school, which would be indirect costs related to this, it would be another roughly $30 billion per year. And they kind of projected this out over the next 20 years. So it's really nearly a trillion dollars in aggregate, or actually a little bit more than $1 trillion when you consider direct and indirect costs over the next 20 years that could be achieved just from getting that 20% or so of individuals with uncontrolled asthma controlled. And this is just purely quantifying it from a financial perspective. It doesn't even account for, this is a metric referred to as quality adjusted life years. So essentially quality of patients' life where they just don't have adequate quality of life. And it's really a huge amount, 700,000 quality of life years per year that are lost essentially to poor asthma control. So I say this just to kind of underscore what a huge, and this is just within the United States, so what a huge kind of burden that certainly severe asthma poses, but also just lack of asthma control, some of which can be achieved with better inhaler use and better inhaler prescription can result in. So this is just to underscore that emphasis on asthma control is critical and will markedly reduce, of course, healthcare costs and more importantly, improve patients' quality of life. This is just saying that although that number is the smaller amount of overall individuals with asthma, they really have this kind of disproportionate symptom burden, both in terms of the impact on their quality of life and healthcare utilization. So circling back to our first take-home point. So, from a practical perspective, I have many patients that are referred to me in clinic, and sometimes just for asthma control, sometimes purely with the kind of query of, I think this, individual may need biologic therapy. And, for the vast majority of these patients, if you actually kind of go and go through to ensure that they're on appropriate step-up therapy per the GINA guidelines, you go over counseling them on their disease, making an asthma action plan, do inhaler education to make sure they're using it the right way, and which inhalers are not very intuitive. Unfortunately, sometimes due to insurance coverage, patients have to switch from inhaler to inhaler. So for all these reasons, this fundamentally, you can actually avoid biologics in many patients with this part of it. So this really needs to kind of always be in the back of our minds to ensure that, one, we have the right diagnosis. Two, we've controlled anything we can. This might include exposures, allergens in the house. Some of these are not modifiable, of course, if it's just dust or humidity outside or fires, or smoke from fires, as we recently experienced. And then again, ensure that they're both using the inhalers correctly and just understand it. It can be a little complex, particularly now with smart therapy. Which inhaler you use on a regular basis, which one you use when you get into trouble. So I think spending time on all of this really pays dividends for asthma control, and often you can actually avoid needing biologics. The other thing about asthma is it's really not a disease that occurs in isolation. So many similar conditions will present in a similar fashion. And anytime you're up titrating someone's asthma regimen without really getting relief, you certainly want to think, well, is this really asthma? Am I dealing with something that's mimicking it? And this is a really great figure to kind of show that all these comorbidities, they interplay with asthma. So one, they can mimic asthma and you actually may be treating the wrong thing. Two, they are all associated with worse asthma control. So we know individuals that have higher BMIs have more severe asthma. Depression, anxiety are associated with worse asthma control, sleep apnea. So really want to make sure that all of these comorbid conditions are addressed. And this is, certainly in the primary care setting, even for me as an asthma specialist, it's really hard to tackle these all independently. So I think it's important that there might be an ENT that you work closely with, for example, to assess vocal cords, or a laryngologist. I think prescribing a PPI or an antihistamine to start gastroesophageal reflux disease treatment is wonderful, but maybe a gastroenterologist that for the patients where the reflux gets more refractory, or they need an endoscopy or something else to better assess it, one that you're working closely with. And it really becomes important to kind of build this network caring for the asthma patient, because undoubtedly many of your patients will experience these comorbidities, and often this is the reason that it's harder to control. And I come across this fairly often. There's a figure I'll show my patients often, because just to kind of exemplify it, which is that reflux can come up, and this is of course just laryngopharyngeal reflux disease. And I always kind of joke with my patients that I never anticipated caring so much, about the stomach and the esophagus as a lung doctor, but it really does interplay so much that you can't isolate the asthma alone without thinking about these things. So before we move on to actually discussing biologics, I really just want to emphasize that before you're getting to that point, you just want to make sure that kind of foundationally, you think you have the right diagnosis. You have individuals on GINA or guideline directed therapy, that they're using the inhalers the right way, both from a controller and as needed per a rescue perspective, and also their actual physical use of it to making sure that it's getting delivered. And then two is really kind of this more global assessment of the individual and their comorbidities particularly those that we showed in the last slide that track along with asthma and can in fact either mimic asthma or worsen asthma. And you'll find that, and I'm sure many of you have found that when you do that, in fact, those patients that seemed quote unquote severe kind of actually move into that difficult to treat category, or just they are able to get control. It just requires a fairly intensive amount of therapy short of biologics. So I think once you've achieved all that, undoubtedly you'll still have patients that, despite all this, either the comorbidities won't be present or they are well controlled, and it turns out it's really just their asthma that's driving it. So then you get to kind of the part where you're saying, okay, this individual truly has severe asthma with exacerbations. And I'll just note that basically all of the studies for biologics were done on individuals that had at least 2 exacerbations requiring prednisone over the last 12 months. So this is really more so for the exacerbator phenotype. And now you essentially want to decide, okay, I'm now thinking about biologics. I need to sort out which one may be the best. And for these individuals, most important, well, I guess all of these are important, but you'll get a CBC with differential, which will give you an absolute eosinophil count. And one thing I'll just highlight there, particularly with severe individuals with asthma that are on oral corticosteroids, it actually can become very challenging to check an eosinophil count off of steroids. So steroids will increase your neutrophils while suppressing your lymphocytes and eosinophil count. So often you'll see asthma patients and you'll look historically and you'll be like, wow, their eosinophil count was almost always 0 or always 10 or 0.01 if you're looking at it in the per thousand. And it turns out that every time it was checked, they were showing up to an urgent care and emergency department and getting, they just tried steroids at home before they came there or something like that. So that's what that little asterisk is denoting, is just to be sure that when you're looking at their counts, you're clarifying if they were on systemic steroids or not. And the threshold there for most biologics is 150 to 300. And then the other kind of measure of T2 immunity is exhaled nitric oxide. So this is typically done in clinic. It's just an exhaled breath and you're measuring the nitric oxide in the airway. And it's a measure of, again, T2 immunity or airway inflammation. Similar to eosinophils, this actually can certainly be suppressed by systemic corticosteroids, but it can actually also be suppressed by inhaled corticosteroids since it's an airway measurement. In fact, in other uses, it's actually used for to see if their individuals are having a response to inhaled corticosteroids. So just keep that in mind as well, that if it's low, just know what inhalers they took that morning before the testing was done. And then importantly, IgE testing should be performed. This is for your more allergic type of, like classically allergic type of asthma individuals that are kind of on the atopic march. And additionally, historically, we've had to have done skin testing for allergen testing, but now that can actually be done via blood. And there are different regional panels based on where you are. And this actually, if they find something that they're clearly positive to and is avoidable, it's possible you may be able to address that trigger without progressing all the way to biologics. And then typically you'll have spirometry. That's largely just to ensure that there's not COPD comorbid, particularly in individuals that have a significant smoking history. Asthma alone, either during an acute exacerbation or over time with airway remodeling, can also reduce your FEV1. And then, as we alluded to, just an exacerbation history to ensure that they would actually drive benefit from the biologic. And then we've talked about comorbidities. There are other allergic comorbidities that I, as a pulmonologist rather than an allergist, don't typically address as often. These would include things like food allergies, urticaria, eosinophilic esophagitis, which all actually have their own indications for biologics. But a lot of what I deal with in my world is kind of the one airway hypothesis, that a lot of what's going on in the nose and sinuses in terms of allergies is also going on in the airways. So if they do have upper airway cough syndrome or upper airway symptoms, one, that's a comorbidity that you want to ensure is addressed before moving on to biologics. And two, it's important to know if they're nasal polyps or not, because that will, there are 3 specific biologics that would be helpful in that environment, or excuse me, in that situation where there are nasal polyps, which would be dupilumab, omalizumab, and mepolizumab, and we'll show those three again in a slide. I'll show kind of a couple of various iterations of this slide or this figure, and I'm sure all of you have seen something like this or some other version of this. This is really, really the result of decades worth of both bench, translational, and clinical investigative work. So nicely summarized, but essentially it's just to show that this is the inside of the airway or the epithelium when we get exposed to whether it's cigarette smoke, pollutants, viruses, fungi. It activates something on the other side of our airways called alarmins, which we'll talk more about later, one of them being TSLP, and causes all these downstream effects with T2 cytokines, ultimately eosinophils, which we're measuring way down here, and also activates B cells, which release IgE, which is our allergen type of immunoglobulin. And these letters here are for where the various biologics act. So omalizumab acts on IgE, tezepelumab on TSLP, dupilumab predominantly on interleukin-4, whereas mepo, reslizumab, and benralizumab all act on interleukin-5. So we'll look at this again. I don't think it's critical to fully, I think it's important to have some understanding of this, but from a kind of purely clinical, practical perspective, it's not necessary to kind of have all the steps of this pathway committed to memory. But essentially, it just all downstream leads to what, the clinical syndrome that we all recognize as asthma. I'll just as a brief tangent. So this is from a paper just a clinical guideline paper we put out earlier this year for measuring exhaled nitric oxide in asthma. And one of the importance is that it's a measure of a T2 phenotype and actually can predict response, of course, to inhaled corticosteroids, but also to biologics. And we're looking, really looking for that over 25 parts per billion cut point. And so this is another version of that slide, and there are right now 6 FDA-approved agents for the treatment of severe asthma. This began with omalizumab, which is targeting IgE in 2003, and then mepolizumab, which is interleukin-5, reslizumab, also interleukin-5, benralizumab, also interleukin-5, dupilumab for IL-4, and then tezepelumab in 2021, which is essentially just much further upstream, and that is the one that hopefully is most beneficial for individuals that don't necessarily have a T2 phenotype. The only other 2 things I want to highlight on this figure, which are a little distinct from the last one, is another alarmin, which is interleukin-33. So we'll talk about some of the data on this. And then again, just to highlight that we're really focusing our talk today on asthma, but ultimately this can lead to other allergic type of conditions that all do have their own indications for biologics, which we are not discussing today. So once you've determined, okay, this individual truly has severe asthma, I've done, optimized their inhaler regimen, their allergic oral regimen with, Montelukast acid, the best I can. I've done their allergen, testing. I've gone over their exposure history. We've reviewed and avoided everything that's possible to review. And they're still exacerbated, and I've addressed their comorbidity. So as you can imagine, I'm very rarely starting a patient on a biologic on their first visit with me. Typically, it takes at least 2 visits, sometimes 3, to be sure that we've really checked off all these boxes before we commit them to this therapy. So once you've determined all that, now you come to, okay, which biologic do I use? And I'll touch upon this in the limitations section, but there's kind of limited data to guide this. But generally speaking, if they're you're truly allergic individual with elevated IgE, with an allergen profile, seasonal variability, maybe they had allergies as a child, that would be an individual that would be a good candidate for omalizumab therapy. And this would be every 2 weeks or 4 weeks, depending on their body weight and IgE level. So this one, if you just kind of search it, it's available online. There's a table in it based on their body weight and what their blood level of IgE is. You'll have a different dose of omalizumab and a different frequency every 2 or 4 weeks. The other one is eosinophilic. So this is your traditional T2 phenotype. They use mepo, dupi, benralizumab, and reslizumab, which are all targeting T2. Mepo is 100 milligrams every 4 weeks. This is for individuals that are 12 years and older. And then you get into a little bit more of the nuances. So reslizumab is a infusion, and it is a weight-based infusion. So the other doses don't actually vary. So for mepolizumab, for example, if you're 70 kilograms, 100 kilograms heavier, your dose is just going to be the same for the other one. So reslizumab might be beneficial for individuals with a higher BMI. It also may address any absorption issues that are occurring because it's an infusion. Of course, the downside is it's not an injectable, so there's no at-home version of this. It's an infusion where they're coming in every 4 weeks. Dupilumab is dosed every 2 weeks, and based on if you're using it for severe asthma versus steroid-dependent asthma, you adjust the dose accordingly. It's the only one that has an FDA approval for oral corticosteroid-dependent asthma. So this one is particularly helpful, for that individual where you just can't get, you literally just can't wean them off prednisone. And I think we've all seen patients like this. You just get down to 5-10 milligrams, whatever it may be, and the symptoms start to have recrudescence. So you just cannot taper any lower. So you're never really able to get a true eosinophil count. So you don't know if they have elevated eosinophils or not because it's predominantly suppressed by the steroid. So dupilumab would be approved for these steroid individuals. The other thing I didn't put here is dupilumab has also been shown to improve FEV1. So if you have an individual where there's airway remodeling, or because you're constantly doing the spirometry when their disease is flaring, their FEV1 is reduced from normal, that might be a good option for them is dupilumab. And then benralizumab, the kind of benefit that it offers is you do 3 doses for 4 weeks, every 4 weeks. And then after that, it's an every 8-week dose. So if you have an individual that maybe doesn't want to do home injections because they don't feel comfortable with it, or don't have family support to do it, or other support to do it, and is coming in the office to get it done, that might be a good option for them. And then the CRS, so this stands for chronic rhinosinusitis with nasal polyposis. That with nasal polyposis part is very critical. So I think this harkens back to a good, sometimes these are so bad you could just see them yourself in exam. Other times they require a full kind of rhinoscopic exam with our ENT colleagues. But if they have chronic rhinosinusitis with nasal polyposis, omalizumab, mepolizumab, and dupilumab are all appropriate for that. There are studies ongoing to see if these medications will be beneficial in chronic rhinosinusitis without nasal polyposis, but currently they've only shown benefit in individuals with upper airway disease and nasal polyps. And we'll come back to this, but I think this is probably a good thing for once you get to the point of determining that an individual meets all other criteria for a biologic. And this brings us into the newer medications. So these are the alarmins. These are, again, there are 3 proteins that are released by the epithelium when we get exposed to typically some kind of exogenous stimuli, whether that's viruses. In some individuals, it's just exercise, humidity, cold air. And the epithelium release TSLP, IL-33, and IL-25. So TSLP, and essentially what this is just going further upstream. So we kind of started at IgE. We moved our way up to interleukin-4 and 5. There have been some studies on interleukin-13 as well. And now we're moving up to the epithelium where things start to get released. So the kind of headline study of this was the Navigator study, which showed that tezepelumab, which targets TSLP, reduces exacerbations. And again, these are individuals with at least 2 exacerbations. Everything to the left of this line means there's a reduction in exacerbations. The only thing I just still want to highlight is that although it's beneficial even in those without elevated eosinophil counts or exhaled nitric oxide, it still is more powerful, or kind of the individuals with T2 inflammation still do derive a greater benefit from this. And that's because you're turning off a lot of that part of the immune system as well. So you see here as eosinophil counts increase, you get a better response. Here's less than 300, more than 300. And same for exhaled nitric oxide. You see this kind of staggered improvement as the exhaled nitric oxide goes up. So all those things might help you counsel your patient. This is true, of course, for tezepelumab, but also for our other T2 agents, that if they have these features, they're more likely to respond. And then interleukin-33 was antagonist. So this is another one of the alarmins, was actually looked at and as a control medication in addition to dupilumab. So it was essentially individuals that were on dupilumab, were not well controlled, and then got added with interleukin IL-33 therapy. That did not show benefit. So as an add-on therapy, it's not necessarily beneficial for individuals that do not respond to dupilumab. It is otherwise, this was just looking at the anti-interleukin-33 therapy, itepekimab, compared to placebo, and it is helpful there. So it's functions at least as well as the other biologics. It just, I think that top line other study was looking for a role as an add-on therapy, which it might not necessarily have. So this paper, which came out last year in the New England Journal, has a couple of nice figures and tables. So this is, the text is a little small, but this first part is essentially, I really think, the most important. I appreciate that the content of our conversation and discussion today is around the biologics, but really critically is just to make sure that you have the right diagnosis, you've addressed all the comorbidities, any avoidable risk factors, you've tested for allergens and taken care of any that can be taken care of, and then address those comorbidities. And then once you've done all of that, then you move down to phenotyping, as we discussed, with eosinophil counts, exhaled nitric oxide, spirometry. And then this essentially just takes us through what we discussed, which is that if they're not eosinophilic, you're thinking about TSLP therapy. Unless they also have allergies, then you can do IgE therapy. And if they are eosinophilic or have an elevated exhaled nitric oxide, you can really use any of the anti-IL-4 or IL-5 therapies. I'd say the only kind of nuanced component here is that there's some data that those individuals that don't have an elevated eosinophil count, but do have an elevated exhaled nitric oxide, will also benefit from anti-IL-4 therapy, which is dupilumab. So that's where the exhaled nitric oxide can offer a little bit more benefit in addition to the eosinophil count. And if their eosinophil count is very high, over 1,500, you just want to be sure that nothing else is going on, such as hypereosinophilic syndromes, allergic bronchopulmonary aspergillosis, and depending on your patient's history, possibly parasitic infections. And then importantly, you're going to be reassessing this within 4 to 6 months. Some individuals will get response literally after the first injection. That tends to be the exception. Most will take 2 to 3 at least to start to see if they're responding or not. So I would give it at least 4 to 6 months to ensure that there's, to basically clarify if there's any response or not. From a side effect profile, they're fortunately fairly benign medications. A very small number of patients will have an allergic reaction, but it's so small it doesn't matter to. We used to do the first injection in office, but that's actually no longer required. Sometimes it can still be helpful practically just to give them instruction on the self-injection and get them comfortable with it, but from a side effect profile, it's no longer necessary. So where we're left with is really a fantastic treatment that has developed over the last 10 to 15 years and changed the landscape of asthma patient or treatment for a very kind of debilitating disease when you get to that level of severe asthma. So it's overall just a very positive development. In terms of limitations, one of them is we really don't have any head-to-head studies. And so this is, we looked at outcomes among all asthma studies dating back over the last few years. And this was not limited to biologics, but just things such as simple as asthma symptom severity or asthma control were only reported in half the studies, FEV1 in a third of the studies. So it's really hard to compare, when you have that pure severe eosinophilic asthma, for example, do I use dupilumab, mepolizumab, benralizumab? We really don't have data to guide that. One possible solution, and this is work that we did with Allergy Asthma Network and had a nice input of patients and patient advocate groups, which I think was very important for a report like this, was a core outcome set. And these outcomes are likely the most important to kind of a broad array of stakeholders, which are severe asthma exacerbations, change in asthma control, and asthma-specific quality of life. as well as asthma-specific hospitalization. So these can be compared, but there's nuances even among the studies as far as what eosinophil count they used, for example, for inclusion criteria, what medications that the individuals were on at baseline. That just makes it very hard to compare, is one medication better than another without a head-to-head randomized controlled trial, which probably will not occur. So, that kind of brings us to our third take-home point, which is that there's limited data to guide which biologic. In terms of what we can use, one is the classically allergic phenotype with an elevated IgE and other positive allergen testing. Omalizumab would be a good medication that those individuals, upper airway symptoms, again, with importantly having nasal polyps. So that would be dupilumab, omalizumab, and mepolizumab for those individuals. And then if they're steroid dependent or have reduced lung function, dupilumab would likely be the best approach there. It's only one approved for steroid dependent, and then that's been shown to reduce FEV, or excuse me, improve FEV1. And then lastly, all other things being equal, and you have an individual or otherwise that just wants to reduce their frequency of injections, benralizumab is good for that population, given it's every 4 weeks for 3 injections, then every 8 weeks. And from that same paper that I alluded to, that was in the New England Journal last year, this is just a clinical review paper. They also have this table, which I think is a nice little bookmark. So I think that figure I showed earlier and this table, if you're kind of in a pinch in clinic or trying to determine, just make a quick assessment about an individual once you've, at the expense of sounding like a broken record, once you've ensured that it's truly severe persistent asthma, you've addressed the comorbidities, they're using their inhalers the right way, et cetera. Once you've done all of that, once you're just trying to figure out which biologic to use, I think that figure in this table are good references to help guide that. The other limitation is that there are individuals, kind of a subset of individuals, that have a high symptom burden, but they don't actually exacerbate. So this is looking at these quartiles or how symptomatic individuals are. And this is how the rate of exacerbations, excuse me. And what you could see is there's actually no increase. So day-to-day symptoms are not a great correlate for frequency of exacerbations. So there is this population where they have these day-to-day symptoms, but actually are not exacerbating a lot. And these medications don't actually confer much benefit in those individuals. There's some improvement in asthma symptoms day-to-day from the main studies and asthma control score, but really the main benefit of these medications, the biologic medications, is to reduce exacerbations and reduce oral corticosteroid usage or dosage if it's a chronic therapy. The other part is that, fortunately, when you get people in that kind of, pure wheelhouse for this, the severe persistent asthma with T2 immunity and now with tezepelumab, maybe even without T2 immunity, not everyone will respond. So fortunately, most people will, at least typically half will have a great response, but about 10, or depending on the study, 15 to 17% of them will actually show no response at all, despite meeting all this other criteria. So there's this question about what to do with them. And one, we actually cannot predict this. So there's no way to really know. You kind of get a feel for it, I guess, but that's not very reproducible or evidence-based. So what we're left with for this is essentially observational retrospective data, which are essentially asthma centers that have encountered these individuals, and they've said, okay, we tried this person, they met all the criteria for mepolizumab, we started them on mepolizumab, it didn't work, let's try switching them to dupilumab. And we've done the same thing here in our asthma center. And basically some groups, this is out of the group at University of Rochester, have reported on this. So for example, this is 83 individuals not on a biologic. You get a great response. So exacerbations go from 5 to 1, severe exacerbations 2 to 0, you're dropping your steroid use. And then this is individuals that fall into that category of, okay, they were on a biologic and it didn't work, and we switched them to another one. You still do get a response, and this is consistent with what we've experienced anecdotally, is there is something that even though you're using maybe 2 IL-5 therapies, one seems to work better than another. So there's something beyond that I don't think we have fully elucidated yet. likely if you're switching, it's probably best to switch from an IL-5 targeting medication to IL-4 or vice versa. So dupilumab to mepo or reslizumab or vice versa, or benralizumab. So you're targeting kind of a different pathway. And this is kind of just a nice schematic of that from a different paper, and they report on their experience. I'm not intending to go through this in detail, but the general kind of takeaway is that if an individual does not respond to the biologic you use, you of course revisit, are they using the inhaler the right way? Are we sure it's severe persistent asthma? Is there a comorbidity going on? And all of those things we've talked about. But once you're sure about this, there is value in switching to another biologic. I think you just have to be upfront with them that we don't know how effective it's going to be, but we're just going to try something different, and there may be they may derive benefit from that. The other kind of limitation of this is the cost. So the average expense is $10,000 to $30,000 per year. There's been cost-effective analyses on this. For the more severe individuals, it's likely still a net benefit because you're of all the healthcare utilization and quality of life adjusted years that we discussed at the beginning, but nonetheless still a very expensive medication, or very expensive class of medications, I should say. Fortunately, the manufacturers of these medications all have various programs that, assuming your patient will fill out, certain forms and things of that nature, generally are able to be much more affordable in terms of the actual out-of-pocket cost that a patient will pay. And then lastly, although it may not matter to some individuals, other individuals do have difficulty with at-home injections. Most of them, 4 of the 6 have transitioned to having a self-injector pen, which is pre-filled. So this has really enhanced the ability to do it at home. And hopefully most offices will have the bandwidth, if needed, to have individuals come into the office, but for the most part, patients will prefer to do this at home and not have the inconvenience of coming in. In terms of future directions, so one is an tezepelumab or TSLP and the alarmins and interleukin-33 is the start of this, which is moving beyond purely the T2 pathway of asthma. So some examples of this are asthma COPD overlap, which has had some focus studies on, and just recently there was an encouraging study for eosinophilic COPD called the Borea study, actually addressing some of these comorbidities. That individuals with asthma that are also obese are different. So might medications targeting them like GLP-1 agonists or GLP-1 agonists be helpful? Sex differences. So there are hormonal and asthma differences between males and females. Might that lend itself to specific therapies? Imaging phenotypes using things like CT scans or MRIs to identify particular phenotypes of asthma that can be treated. There's studies called a PRECISE study, which is kind of an adaptive study. So they measure certain proteins in the blood, and based on that protein, you get a specific treatment. And that kind of brings us to this other thing of just, can we actually predict how well a particular individual might respond to some particular medication? So at the moment, we have some guidance on which biologic to start, but it's not a huge list and by no means definitive. So is there a way that we can really transition to the era of kind of precision medicine where we say, okay, this person would benefit most from mepolizumab, this person would benefit from dupilumab, this person would benefit from tezepelumab, et cetera. And I put immune fingerprint, that's just one example. There are many other ways, whether it's imaging, blood testing, genetic testing to try to, that are being studied to try to figure out how to do this more effectively. So in terms of take-home points, and then I'll be glad to review or address any questions, is number one, and I think I'm probably up to 7 times on saying this, so I think I was targeting for 5, so I said it even more than I intended to, but which is to ensure that you have the accurate diagnosis and you're just doing the fundamental stuff right. That's really a big part of it. As we kind of reviewed at the top, that's 80 to 90%, maybe 95%, depending on the population of individuals with asthma. So it's just ensuring you have the right diagnosis, addressing comorbidities, make sure they're using inhalers the right way, and avoiding any exposures possible. And then as I've mentioned, full assessment and therapies of comorbidities, which can interact with severe asthma. And then lastly, as we've discussed, there's some but limited data to guide which biologic, and it's really summarized here, which is if they're allergic, if they have nasal polyps or other allergic comorbidities like food allergies, urticaria that have not been reviewed here, if they're steroid dependent or have reduced lung function, and then the frequency of injections. And again, just this table as a kind of nice reference for this. So with that, I'll close and thank you all again for your attention, attending, and to the Allergy and Asthma Network for providing me the platform and opportunity to review this.
Well, thank you, Dr. Tejwani. This has been extremely informative. I'm going to start with a couple of questions that we have from our attendees. One of those is looking at access. So what are some of the access issues you've encountered when prescribing biologic treatments for patients with asthma?
Yeah, that's a really great question. So I think the biggest access issue is more of a, global access issue, which is, unfortunately, if patients don't have a primary care doctor, they're not getting referred to a pulmonologist, they're not kind of going through the whole pathway that we're talking about. They're just kind of getting repeatedly prescribed prednisone, maybe utilizing the urgent care emergency department, or of course, they're just getting prednisone. So I think that is really the kind of funnel or kind of narrow point. Once they're in our group and kind of going, or in, I think, seeing a pulmonologist or an allergist and going through everything, fortunately, despite the cost of the medication, they're really with enough persistence, both on the back end of our administrators and the patient, we are able to get it. But that being said, all of that takes time, right? That takes an individual with, one, navigating the healthcare system to get there. Two, they are responsible for some of those forms, which carries a certain educational, threshold and socioeconomic threshold to have the time to navigate all of that. So I think once they're in, we can fortunately work with them to get something, but I do think there's some hurdles to get to that point, and then there's some exceptions where we can't, get the right. But I will say it. Generally, the manufacturers they each have their own assistance program for patients, and I would say generally, if they'll fill the forms out, which are onerous, it usually can happen.
Great. Well, and we at AAN do have a helpline, if you will, with prescription drugs for asthma. So that may be a resource we could share afterwards. One of the other questions that I think is interesting here is that someone is asking, what have you heard or seen in regards to inhaled biologics for studies, or have you seen anything like this at all?
Yeah, that's a great question. And I looked again, I've seen some oral medications, but so far none that really are meeting muster. But I think there is an idea to try to do that. There's another nebulized medication, enfuristone, which just came out for COPD. It's a phosphodiesterase inhibitor. And then for asthma, there are some other oral medications being studied, but to my knowledge, I haven't seen any inhaled biologics that have been tested yet.
Great. We do have some testimonies here within our question and answer, and it's amazing to see the testimonies that patients have shared with us, or healthcare providers have shared with us, that they've had success with biologics and that asthma is being managed. People are asking for a copy of the slides, and I would have to say that would probably be available after today as one of the supplemental documents. And the last question here is, which of the biologics helps most in reducing airway remodeling?
That's a great question. I think the short answer is we don't know. I would maybe dupilumab, and I'm just using it as a proxy because of the improvement in FEV1, but I just want to be very transparent that that's me speculating. We don't really know the answer to that. And tezepelumab may meet that threshold just because it's higher up in the inflammatory pathway. We just don't have enough data on it yet. So I think that's a great question. Any of the which of the does this most questions, just to be very open with you, are we really can't answer definitively just because of the absence of any head-to-head studies.
Yes, absolutely. I'm not sure if this is correct, but it says, do you see any future role for targeting TGFB?
Yeah, so I think that's a great question. So as far as targeting transforming growth factor beta 1, I
you.
was actually very interested in this as an early part of the research I did as well. So I think possibly the issue that which is, so TGF beta 1 is a protein. It in particular is responsible for airway inflammation, remodeling, smooth muscle remodeling. So a lot of the changes we see in the airways. I think the challenge with it is, unlike some of these targets, which fortunately, like I always sometimes when my patients hear biologic, they might be familiar with lupus or rheumatoid arthritis, where we're targeting things like interleukin 1 or TNF alpha that kind of have a lot of other benefit. Fortunately, interleukin 4, interleukin 5, the eosinophil pathway, that it's not really that useful. So TGF beta, although I think it's certainly deleterious when it gets out of whack, the challenge with it is that it also has some likely beneficial immune components to it, or I would say does have some beneficial immune components to it. So the challenge would be, how do you target the specific downstream pathway that's bad from TGF beta, whereas you leave the kind of good part of it alone.
That's really interesting. That's really interesting. I hadn't thought about that. So thank you for bringing that to my attention. Someone is asking if you could please repeat how soon after injection from the biologics should patients see an improvement?
Yeah, so I usually counsel my patients on waiting 6 months before they reach a verdict.
Okay.
These are most of them will see benefit before that. These are individuals that have certainly, by the time they're at this point, have really been struggling for some time, naturally very frustrated and kind of really looking for a cure. And the reason I say that to them is that it's just, I don't want them to, at 3 or 4 months, they don't feel better, and it just turns out they just need another couple months. But I would say you should, on the counseling side, I think as a provider, you want to, like we say, 6 months just to give yourself a little cushion. But from a practical perspective, at about 3 to 4 months, they should start to see benefit.
Okay.
And I'm just coming back to this slide, which just, they say after 4 to 6 months, but I think on the counseling side, you're good on 6 months.
Great. The person always also asks, what if a person misses an injection? How will that impact?
Yeah, that's a great question. So one thing we didn't touch upon is stopping biologics, which is another kind of limitation, which is how long and what do we need to do. So I have some patients that, for example, for mepolizumab, when they are at week 3 or 4, they will literally start to feel symptoms getting worse as they're nearing that 4-week threshold. So generally speaking, once you've gotten somebody once somebody's at this point, they really should not miss an injection, just to be open about, that it will likely be harmful. The caveat to that is, if they do miss it for some reason, they're traveling, or often what happens is there's some lapse in the renewal. So I'll just say, from a practical perspective, we let our patients know now and try to keep them on our radar for month 10 or 11 to contact us, or we contact them to start the renewal process, because typically the approvals for this will last 12 months. But in a way, if they do miss it for whatever reason, it's a little bit of a natural experiment, just because if they miss it and they don't feel much worse, you might want to revisit how much they need it. Because usually patients that are on this, once they miss even just one, within a couple weeks, they'll feel the difference.
There's one, I think we have time for 2 more questions. One of these is, is there any likelihood of certain genetic profiles, because we did touch base about genetics, but are there certain genetic profiles that with severe asthma that respond better to the biologic?
Yeah, I think yes. I think yes, but not ready for clinical practice. So The two kind of longer answers to that. One is there's efforts to develop something like a polygenic risk score. So it's beyond just using a SNP or a variation in a single gene and saying, okay, let's take these 10 genes together and kind of create a risk for that individual. The other thing was we talked about IL-33 therapy. So that's also been studied in COPD. And with the COPD study, they looked at genetic variations in that interleukin 33 gene as a modifier to therapy. And it does seem that individuals with certain mutations in that have a better response to the IL-33 therapy. So I think there will be. So whether it's going to be genetic, or there's also studies where we do nasal swabs and look at RNA or transcriptional expression in the nose or protein. So I think some combination of this, probably within, hopefully 5 to 10 years, maybe longer, will make its way to clinical practice.
Oh, yeah. That'll be an interesting day, right? When we can see all of the DNA of what's going on with our patients. That will be a eye-opening experience.
Yeah.
So one of the questions that you and I talked about a few minutes ago was, the consensus statement that just came out from ATS, Quad AI, and the college about the concept of remission. So what are your thoughts about the concept of remission as it applies to these biologics treating severe asthma?
Yeah, no, I think it's great. And I think it's as we discussed, Edie, great. I think it's always nice to have definitions of things, particularly in the research space. I think from a practical clinical perspective, this is something we've all kind of done with maybe not articulating it, but we have individuals where I'm seeing them every 1 to 3 months, and then they go into quote unquote remission, or now we have a definition for this and we're spacing out visits. We're not checking in as often, et cetera. So I think it's great that to have kind of an agreed upon consensus definition. And then in terms of the implications here, I think what it can help guide us on, which we have kind of limited data on, and I touched upon, is when to stop this. So we don't have great evidence on that, but if somebody goes into maybe, full remission for 2 years, I'm just saying that hypothetically, or whatever duration of time we kind of agree upon, then maybe then we try them off the biologic, for example. So I think that's where I think it could play another role in asthma therapy biologic therapy is, well, one, monitoring response. So essentially the biologic should induce remission. And then two, after some period of time in remission, can we stop the biologic or see how they would do off of it?
Right. Yeah. Well, again, thank you for your time today. We are at time, so we really appreciate everyone attending. We do have another webinar coming up next week on September 26th when we'll welcome Dr. Rajal Merchant from Common Spirit Health, who will discuss aspirin exacerbated respiratory disease, AERD. Look for upcoming webinars in October, as well as the topics about smoking cessation and atopic dermatitis. You'll receive an email from us. It'll come from Zoom in a few days with a link to the recording, an evaluation, and the supplemental resources. Thank you again from all of us at Allergy Asthma Network. Join us as we work every day to breathe better together. Thank you.